Hi, I'm Richard Barr from Southwoods Imaging in Youngstown, Ohio. Today I'd like to give you a talk on an overview of breast ultrasound highlighting the BI-RADS classification. Today I'd like to give you a general talk on ultrasound imaging of the breast, talking about lesion characterization. I'd like to go over some of the things that I do when I'm doing an examination, as well as review the BI-RADS categories and characterization of lesions. The first thing that I think you need to do when you're doing a breast ultrasound is to decide if you're doing a detection exam, meaning that you're doing a diagnostic workup for a clinical finding or other imaging finding from mammography or MRI, or if you're doing a screening examination. If you're doing a detection examination, that is, that the patient has a symptom or a problem that you're trying to further work up, then you also need to decide if you're going to do a targeted exam to only include that area that's abnormal, or you're going to do a whole breast ultrasound. There's no real guidance as that one is better than the other. I think that your institution should make a decision so that you have uniformity throughout your division. If you're going to do a targeted exam, one thing you have to remember is the breast can roll when a mammogram is being performed, and therefore I prefer to scan over 120 degrees, that is 20 minutes on the clock face, from where I think the lesion is. So if I believe the lesion's at 2 o'clock on the mammogram, I always scan from 12 o'clock to 4 o'clock. I always take a picture of the farthest clockwise and the farthest counterclockwise image of where I scan for documentation. This way you can go back and you always remember at what locations you've scanned in the breast. I always perform scans in two planes, and I prefer the radial and anti-radial, but there are you can do sagittal and transverse if you prefer. Another thing that I think a lot of people don't realize is if you're going to be scanning the entire breast looking for lesions, you do need to scan superior up to the clavicle, inferior to the inframammary fold, medial to the midline, and lateral to the mid-axillary line, and we also include the axilla as part of a whole breast examination. I always document at least one image in each quadrant, even if no lesions are present. Again, that's just for documentation that that area of the breast was scanned. If there are greater than 4 cysts or well-circumscribed solid lesions, such as fibroadenomas that we see in patients with fibrocystic disease, I usually take only one image to document the size and position for further follow-up and really just characterize one lesion in each quadrant, which is either the most suspicious or the largest. When we find a lesion on ultrasound, we want to use the breast imaging and reporting data system BI-RADS to characterize that mass. The BI-RADS classification includes a discussion on masses, calcifications, special cases that are unique to ultrasound, vascularity, and an assessment category. To be able to characterize a lesion, you have to have excellent B-mode images. You need to evaluate the entire lesion. It's not sufficient if you see a lesion that you think is a cyst to just take a transverse or a radial and an anti-radial position and not interrogate the entire cyst wall. You do need to look for subtle findings as for irregularity of the masses or small spiculations. This will help to put the lesion in the appropriate BI-RADS category that we'll discuss later on for the patient to have appropriate treatment and follow-up. In terms of masses, one thing that we want to do is shape. This can be either oval, which is elliptical or egg-shaped and may include 2 or 3 undulations, round, spherical, ball-shaped, circular, or globular, irregular, neither round nor oval in shape. And here are some examples of these 3. Oval, round, and irregular. Oval is usually characteristic of a benign lesion. Round is intermediate, and irregular is more suspicious for a malignant lesion. We also want to describe the orientation of the lesion. Is it parallel? The long axis of the lesion parallels the skin line. otherwise stated as the lesion is wider than taller or horizontal, or it's not parallel. The long axis is not oriented along the skin line, meaning that it's taller than wider or vertical. And here are examples of parallel, where the long axis of this lesion parallels the skin, and not parallel, where the lesion is taller than wider. Not parallel is more suspicious for malignancy. Parallel is more suggestive of a benign lesion. Margins. These can either be circumscribed or not circumscribed. By circumscribed, we mean the margin that is well defined or sharp with an abrupt transition between the lesion and surrounding tissue. Not circumscribed, the mass has one or more of the following features. It can be indistinct, no clear demarcation between a mass and its surrounding tissue. Angular, some or all of the margins have sharp corners, often forming acute angles. It can be microlobulated, where there's short cycle undulations imparting a scalloped appearance to the margin of the mass, or it can be spiculated, where the mass is formed or characterized by sharp lines projecting from the mass. And here we have examples of all of these. Circumscribed, again, clearly defined margins. These are often benign. Indistinct, where here we have a hypoechoic lesion going to a hyperechoic rim, and it's very hard to determine exactly where the transition is between those, so the borderline is indistinct. Angular, you can see we've got several irregularities here in the mass with angular margins, again more suspicious for malignancy. Microlobulated, we've got several well circumscribed undulations, and a spiculated mass, where we've got multiple spiculations coming out of the mass, more suggestive of a malignancy. We want to look at the lesion boundary. You can either have an abrupt interface, meaning that there is a sharp demarcation between the lesion and surrounding tissue, which can be imperceptible, or a distinct, well-defined echogenic rim of any thickness. We can also have an echogenic halo, where there's no sharp demarcation between the mass and surrounding tissue, which is bridged by an echogenic transition zone. Here are some examples of an abrupt interface in this epidermoid cyst, and you can clearly define a very well-defined border of this lesion, and you can pinpoint in one location or one pixel where the lesion begins and ends. In the image on the right, we have an echogenic halo. Again, we have a hypoechoic lesion that kind of fades into the hyperechoic rim and then fades into the adjacent tissue. So it's very hard to determine where the boundaries of this lesion are. We want to describe the echo pattern: anechoic, without internal echoes; hyperechoic, having increased echogenicity relative to fat or equal to fibroglandular tissue. And again, in breast imaging, we always want to describe the echogenicity as compared to fat. The lesion can be complex. It's a mass containing both anechoic and echogenic components. It can be hypoechoic, defined relative to fat. Masses are characterized by low-level echoes throughout, that is, the appearance of a complicated cyst or fibroadenoma. Or it can be isoechoic, having the same echogenicity as fat. A complicated cyst or fibroadenoma may be hypoechoic or isoechoic. And here are some examples. Anechoic in this simple cyst. Hyperechoic, where the lesion is uniformly increased in echogenicity to the adjacent fat. If you see such a lesion as this, it's very important that you scan through the entire lesion and make sure that the entire lesion is hyperechoic. Those lesions are most often benign. However, you need to be aware if there is a hypoechoic central area, you may be looking at a malignancy with a large hyperechoic rim of surrounding tissue. So again, in these hyperechoic lesions, make sure you interrogate the entire lesion and that they're uniformly hyperechoic throughout. Complex, having both anechoic and echogenic components. Isoechoic in this lipoma. And hypoechoic, again compared to fat up here. And most malignancies that we're going to be looked at are usually hypoechoic or very hypoechoic. We also want to look for posterior cutial features. There's no posterior cutial features, meaning there's no posterior shadowing or enhancement. We can have enhancement where there's increased posterior echoes, shadowing where there's decreased posterior echoes and edge shadowings are excluded. We can have a combined pattern where there's more than one pattern or posterior attenuation, both shadowing and enhancement. And here are some examples. We have two simple cysts. Here one we have in the same patient, very good through enhancement, and the other one has no features. Here's an area of shadowing, and this lesion has both through transmission and areas of shadowing. We also want to look at the surrounding tissues. We want to look for duct changes, so we want to look for an abnormal caliber and or arboration of the ducts. We want to look at Cooper's ligament changes. Are they straightened or thickened? Edema, which is increased echogenicity of the surrounding tissue, a reticulated pattern of angular hypoechoic lines. Architectural distortion, where there's disruption of the normal anatomical planes. Skin thickening, where there's focal or diffuse skin thickening. Normal skin is approximately 2 millimeters or less in thickness, except in the peri-areolar and the lower portions of the breast. We also want to look for skin retraction or irregularity, and this is where the skin surface is concave or ill-defined with an appearance that's pulled in. And here are some examples. You can see that these ducts are enlarged, and they have areas of focal narrowing and contain some internal debris. Here we have edema, where we see this anechoic or very hypoechoic fluid tracking along all the fascial planes. Here we see the Cooper's ligaments are destroyed by this mass. So whenever we see Cooper ligaments, we really have to be concerned about malignancy. I think that when we see destruction of the Cooper's ligaments, that's telling us that that mass is very aggressive and is most likely going to be a malignancy. When we see edema, I think in our practice we see edema more from patients that have congestive heart failure or hepatic or renal disease as opposed to patients that have a malignancy. Architectural distortion. Here you can see that the normal anatomy of the breast is distorted. Skin retraction. Here you can see that the skin is concave. And what I like to do is I like to use a lot of gel to fill in that concave portion and apply very little pressure so that we actually get an image that documents how much the skin is retracted, so we can compare that in the future. If you wanted to get a little bit better imaging inferiorly, you may want to push then, but you'll lose that appearance of the retraction. For skin thickening, what I like to do is do a dual display, and you can do the normal and the abnormal side in the same location. So you can compare the skin thickness from one breast to the other, and I find that very helpful. For calcifications, we look at macrocalcifications, and these are greater than or equal to 0.5 millimeters in size, and these calcifications usually shadow. And we can have microcalcifications out of a mass, or we can have the microcalcifications within the mass. And these small microcalcifications outside of a hypoechoic mass are very difficult to identify because they do not shadow. However, if these microcalcifications are in a very hypoechoic mass, they are often seen as punctate foci within the lesion. And here are some examples of a macrocalcification where we see shadowing. And here we have microcalcifications that we can see within a hypoechoic mass. And in this case, you can see there's several white dots. And here's a macrocalcification with shadowing, but there are multiple other small white dots in the normal breast parenchyma, which is very hard for us to determine if these are really microcalcifications. Ultrasound is very unique. It allows us to actually characterize lesions with specific features and can classify them as benign or malignant. So clustered microcysts are a cluster of tiny anechoic foci, each smaller than 2 to 3 millimeters in diameter, with thin, less than 0.5 millimeter intervening septae, with no discrete solid components. Complicated cysts are mostly characterized by homogeneous low-level internal echoes. Complicated cysts may also have a fluid-filled or fluid debris level that will shift with the change in position. It's very important to distinguish complicated cysts where there is no solid component that's fixed to the wall versus complex cystic masses which have a solid component and do not move with repositioning of the patient. We can look for a mass in or on the skin. These are usually clinically apparent and may include sebaceous or epidermoid inclusion cysts, keloids, moles, and neurofibromas. And here's an example of a clustered microcyst with these very fine septations. Here's an example of an epidermoid cyst as a mass in or adjacent to the skin line. And here's a complicated cyst that has some debris inside a cyst. Additional special cases include foreign bodies, and these may include marker clips, coils, wires, catheters, sleeves, silicone, and metal or glass related to trauma. We can also see lymph nodes. They can be either intramammary or in the axilla, and these are normal findings within the breast. And lymph nodes resemble small kidneys with an echogenic hilus and a hypoechoic surrounding cortex, and again, they're found normally in the breast, including the axilla, and just because you find them does not mean that they are abnormal. So here's an example of an intramammary lymph node. One of the things you want to do to make sure it's a normal lymph node is that the hypoechoic cortex is relatively uniform throughout its appearance. Again, you're going to have an echogenic fatty hilum. Here's an axillary lymph node which has the same appearance, and here I've turned on color, and that's to show you that in a normal lymph node, the artery and vein enter through the hilum and have a pattern just similar to a kidney, this normal arboration. If you ever see blood flow coming through the cortex from out instead of through the hilum, those lymph nodes are abnormal and need to be biopsied. And here's an example of a foreign body, a needle taking a biopsy. We also want to assess vascularity, and there may be no vascularity present or it's not assessed. That the vascularity can be present within the lesion. It can be present immediately adjacent to the lesion, or we can have diffused increased vascularity in surrounding tissue. So here's an example. We've got the color box turned on and there's no blood flow. You do want to make sure that you have your settings appropriate and that you get blood flow. And usually we try to get at least a dot of blood flow, not in the lesion, but in the surrounding tissue to make sure that our settings are correct. In this case, we've got blood flow surrounding the lesion and not within the lesion. If these vessels tend to drape around the lesion, it's more likely a benign lesion. Here we have blood flow within a lesion, and this does not necessarily have to be a malignant lesion. In general, benign lesions have blood flow that surrounds the periphery of the lesion before entering. In malignancies, we often have vessels that are perpendicular to the lesion, giving more appearance of a malignancy. And we can have diffuse increased vascularity, in this case with mastitis. So after you've found your lesion and you've characterized it using the words we've just described, the next portion of the BI-RADS is the assessment category. And there are 7 assessment categories. These include Category 0, incomplete, Category 1, negative, Category 2, there is a finding, but it is definitely benign, Category 3, there is a finding and is probably benign and must have a less than 2% probability of a malignancy. Category 4 is a suspicious abnormality, and these are subclassified into 4A, 4B, and 4C, with the percentages of malignancies listed here. Category 5 is highly suggestive of malignancy, greater than 95%, and Category 6 is a known cancer. Your report should give a concise summary of the clinical history, comparison to previous ultrasound examinations. You should tell the scope of the exam if it was a targeted exam or a survey exam. And you want analysis of significant lesions or findings. You want to say the type of breast tissue, lesion size given in at least 2 dimensions, and the location. I prefer to give the clock face and distance from the nipple. There are other methods you can use to describe where the lesion is. You want to give a succinct characterization of abnormal findings. And then you want to do correlation of the ultrasound with mammography or MRI if available. And then you want to give your overall final assessment using the BI-RADS classification that we just discussed. And from that BI-RADS assessment, you want to give your management recommendations, and those flow based on the BI-RADS category. So if you have a BI-RADS 3 lesion, you will probably recommend a 6-month follow-up. If you have a BI-RADS 5 lesion or a BI-RADS 4 lesion, a biopsy is usually recommended. Important points to remember is that the most diagnostic information is from the B-mode image. So you really want to have good technique, and good equipment is a must. You want to, documentation is important for comparison to other modalities and follow-up examinations, as well as medical legal issues. And remember, when you're doing comparisons to other modalities, always confirm the position of the lesion, the background tissue, and by that I mean is if you have a mammogram and the lesion is in fatty tissue, you should also find the lesion on ultrasound in fatty tissue. And again, correlate the size and shape of the lesion should be the same on both modalities. And if they're not, you have to be concerned that the lesion that you have does not correspond to the lesion on the other modality. Probably the hardest part of this is the BI-RADS assessment. Some are pretty easy. If you have a simple cyst, it's a BI-RADS 2. If you have a spiculated mass with blood flow and shadowing, it's a BI-RADS 5. However, the majority of these lesions are in the middle, and experience is very helpful in determining the appropriate assessment category. You should always follow up your assessments to see how you've done. And I gave you the percentages of lesions that should be malignant for each of these categories. I think it's very important that you do your follow-up and realize if you're overcalling, undercalling cases. So, for example, if you're calling lesions BI-RADS 3 and you notice that 10% of those are malignant, you need to readjust your scale because we should not be calling greater than 2% of your lesions, no greater than 2% of the lesions you call BI-RADS 3 should be a malignancy, and actually in most studies that should probably be less than 1%. So in conclusion, BI-RADS has resulted in a uniform reporting system that we all understand. Lesion characterization requires attention to detail and looking for subtle findings. If you do a good job, your surgeons will want you to do the workup. I think that when we started, our surgeons were a little reluctant to have us do biopsies, and as we've done a very good job also evaluating lymph nodes, also looking for other lesions, and we can present them with a very high quality examination and provide them the information they need. I think this eliminates a lot of problems with disagreement between who should be doing what. Lesion characterization and recommendations is not enough. You need to look at the whole picture. So, for example, whenever there's a cancer, we really search for abnormal lymph nodes and biopsy those if needed. And again, if we also look for a second cancer to make sure we do a complete study. Thank you for your attention.